Hey, it's John. I just wanted to talk a little bit about COPD. So, one of the important considerations is oxygen therapy. Normally, a person has an SpO2 of 95 to 100%. The oxygen capacity of your blood is 95 to 100% full. In COPD, people often have reduced oxygenation. Oxygen therapy is started for these people. If I were to hold my breath, my body would start using up the oxygen and my blood level of CO2 would start increasing. Receptors in my body would start noticing more acidic as CO2 increases in my bloodstream. And these receptors are going to scream to my brain and tell me that I need to breathe. Increasing CO2 is going to drive my respiratory effort. In chronic obstructive disease, the movement of air and the movement of gases from the blood into the lungs are both impaired, and the body gets used to the high CO2. And what happens if you have COPD and you hold your breath? Peripheral receptors are going to start noticing O2 levels falling. Low oxygen is what screams at your brain and says you got to breathe. The problem being is that when you start adding supplemental oxygen, what you're doing is removing the respiratory drive. In COPD, high CO2 levels become normal. The patient's body begins relying on low oxygen to drive respiratory effort. It's our nature or our job to care for our patients and make them as comfortable as we can. So there might be a desire to put oxygen on a COPD patient and turn it up and make them really very comfortable. But in COPD, the patient really needs to be a little bit short of breath so that they're huffing and puffing and blow off more CO2. If they're very comfortable, the respiratory drive can be suppressed to the point where they're retaining CO2, may even becoming confused from the level of CO2. Thanks for watching. Subscribe and share if you would. I'd appreciate it. Bye-bye.